Alrighty, let's get started. Welcome everybody to the F2G breakout session. For those of you that don't know me, I'm Luis Ostrowski. I'm one of the MSG members, and it's a pleasure to share this room with Emma Harvey, who's gonna give us a presentation on F2G, what they've been doing, where they are, where they're going. And the idea of this breakout rooms is to be very, very interactive, where you guys get to ask questions to the company, and the company also gets to solicit input from us. So without further ado, I'm going to turn it over to you, Emma.
Thank you, Luis, and thanks for having the opportunity to talk to everyone today. So I'm Emma Harvey. I'm Global Head of Medical Affairs, and I know that a couple of my colleagues are sitting in the audience as well, so they may pitch in to answer questions as we go through. I'm just going to take you through a very few slides about Allurifim. You've already heard about it earlier today, but Allurifim is an erotamide antifungal agent. It's a novel class of antifungals. And the mechanism of action is selective inhibition of fungal DHODH type 2, and that impacts fungal pyrimidine biosynthesis. Allurifim's fungicidal for Aspergillus and for other filamentous fungi, including some with no current standard of care, including Lamentaspora prolificans and Scopulariopsis species. And it's equally active against wild type and azole and amphotericin B resistant Aspergillus species. Allurifim has been granted breakthrough therapy designation by the FDA, as John mentioned earlier on, and that's based on preliminary clinical data that we were able to share with FDA. It's currently in phase 2 trials, where we've been able to demonstrate that a fixed dose regimen is effective and well tolerated for most patients. There's no need for routine therapeutic drug monitoring. And for most, for what we've seen in terms of drug-drug interactions, these are very limited. They're predictable and manageable drug-drug interactions. So phase 2 is well underway. We're about 3/4 enrolled in our phase 2 study. And we have a phase 3 study in invasive aspergillosis ready to start enrolling. We're really just waiting to get over the hump of this current Omicron variant, in the hope that centers will be able to initiate the study and get going with enrollment. I'm just going to show you a short time-lapse video. This shows the fungicidal activity of Allurifim. So this is a 16-hour-old Aspergillus fumigatus hypha, actively growing, treated with 0.1 milligrams per liter of Allurifim. And what you'll see is initially the hypha starts to grow, then growth is truncated, the hypha starts to swell, and about 24 hours after incubation, you'll see cell rupture. So there's a cell rupture, and you can see other areas of the cell also starting to swell. But unfortunately, we only had 48 hours of time-lapse photography, so you don't see the additional cell ruptures there. MICs for Aspergillus, Scedosporium, and Lopro isolates are all very well grouped together using CLSI methodology, with plates here read at 48 hours for Aspergillus and 72 hours for Scedosporium and Lamentaspora. You can see that the vast majority of those MICs are below 0.05 milligrams per liter. And we've tested to date somewhere in the region of 8,000 clinical isolates of different fungal species, including over 6,000 Aspergillus isolates, and that includes a number of cryptic species. We've tested over 300 Scedosporium and over 100 Lopro isolates, and we get this consistently low pattern of MICs. We have a phase 2 open label study currently enrolling. We've enrolled over 150 patients with a variety of mold infections, including invasive aspergillosis, Scedosporium, Lopro, coccidioidomycosis, Scopulariopsis, and some other rare mold infections. All patients have been dosed with oral Allurifim to date, including patients with things like gut GVHD. And Allurifim has been well tolerated in this population over a median duration of therapy of around 12 weeks and a maximum duration now of more than 2 years in a small group of patients who've had difficult to treat infections such as CNS coccidioidomycosis. As I mentioned, drug-drug interactions have been limited and as predicted from our models, And we've been able to dose these patients with drugs such as ibrutinib, tacrolimus, and other challenging agents without the need for significant dose changing. And complex and slowly resolving infections such as cerebral aspergillosis and osteomyelitis due to low-pro have been readily managed with extended dosing, and Allurifim is well absorbed into tissues such as the brain and the bone. We have, as I mentioned, a phase 3 trial ready and waiting to go in a number of centres. We're just waiting for initiation now, really waiting for centre managers to give us the go-ahead. And this is a phase 3 trial of Allurifim for the treatment of invasive aspergillosis. It'll be 90 milligrams twice daily of Allurifim compared with initial Ambisome intravenously, followed by standard of care with standard endpoints at 84 days. And there is the potential for extended therapy for these patients at the end of 84 days on clinical trial. And the enrollment criteria are patients who have probable or proven invasive aspergillosis in patients for whom an azole would not be appropriate, including azole resistance, predicted drug-drug interactions, breakthrough on prophylaxis, and acute refractory disease. Excuse me, there's a typo in there. And EORTC, MSG response, and all-cause mortality are the main efficacy endpoints. And as I mentioned, there's an extended therapy protocol available after 84 days. So that was a whistle-stop tour, and very happy to take any questions from the audience. Luis, you're muted.
If I had a nickel for every time that happens. So the first question we have on the chat is, why did you choose Ambisome and not voriconazole for a comparative study?
Number of reasons, some of them very practical, but actually when we're looking at, there have been a number of studies done now with the azoles. So if you think the last few years, we've seen the publication of the isavuconazole study. Last year, we saw the publication of the posaconazole versus voriconazole study. Very little to choose between those three agents. And I think when it comes to whether the term is straightforward, uncomplicated, invasive aspergillosis, or that may be the wrong term, but actually generally invasive aspergillosis is well served by the azoles. We know that they have good outcomes and good tolerability, but there are patient populations for which there is no true standard of care. And so we chose not only Ambisome as the comparator, but a population of patients who have not been addressed in clinical trials, but who present very real clinical challenges, such as breakthrough following azole prophylaxis, and such as those patients receiving novel immunomodulatory agents like venetoclax, ibrutinib, where actually the use of the azoles may be quite challenging. And so, Ambisome by default has become the drug of choice in that setting, or whether it's Ambisome or whether it's lipid formulation of amphotericin B, but that tends to be the standard of care in those patients. And so we chose Ambisome as our comparator for the study.
All righty. I'm gonna remind the attendees to please type your questions in the chat, or if you wanna do your question live, just raise your hand and I'll call on you. Do we have any other questions for Emma?
Very happy to take it live if somebody wants to go on camera and
well,
ask.
people think I'm going to ask you, what's the expected plasma level of Allurifim?
Actually, I don't know that off the top of my head. I don't know. John is on, I think, was on the call, unless he's moved on. John, do you have the plasma level off the top of your head?
Oh yeah, absolutely. So our mean trough is around like 0.6 or 0.7, and our mean peak is around 2.5. So more than 95% of subjects sit north of 0.2 to 0.3 and south of 4.
Very good. We have a question from Marcio, who's asking, no cytochrome P453 inhibition, and any new data on Allurifim and fusariosis.
So in terms of cytochrome P450, there is some very mild CYP3A4 activity. So actually, if you're, you may need to do some dose changing, particularly if you co-administer with an azole, for example, which are inhibitors of CYP3A4, then you will need to adjust the dose of Allurifim downwards. So the standard dose at the moment is 90 milligrams twice a day. We don't expect that to change. And with if you co-administer with fluconazole, voriconazole, or posaconazole, then you may need to do a dose reduction down to 60 milligrams twice a day. Likewise, if you give with something like rifampicin, then you may need to change the dose upwards. Drugs such as tacrolimus, you may need to reduce the dose of tacrolimus about 30%, but that should be driven by doing your dose levels for tacrolimus, likewise with cyclosporin. So there may be some need for dose adjustment for agents like that. But for things like the tyrosine kinase inhibitors, there's no need for dose reduction. Was the other question on fusarium?
Yes.
So fusarium is an interesting conundrum that we're evaluating at the moment. Allurifim seems to have variable activity against different strains of fusarium. So what I would say is no definitive answer at the moment. Watch this space. We're doing a lot of work to try and evaluate how Allurifim works against fusarium.
Any other questions in the chat or that anybody wants to ask live? Can you meanwhile talk to us about CNS penetration?
Yeah, so we presented some data last year at ECCMID looking at tissue distribution, and in fact penetration into the brain is very good. We're seeing levels in brain tissue that are equivalent to plasma levels, and in fact that's been correlated in good responses we've seen in the clinical trial with patients who've had a range of brain infection, including azole-resistant aspergillosis and CNS cocci. Allurifim is very very protein bound, so we wouldn't expect to see it actually in the cerebrospinal fluid, but we do get measurable levels and therapeutic levels in brain tissue.
Very good. And then Monica is asking any more detail on the risk of hepatotoxicity.
So I know that Andre mentioned hepatotoxicity earlier on. We have seen hepatotoxicity as the most important adverse event in the study. The rate at the moment is running at about 8% of patients. It's actually manifested by an increase initially in ALT and AST. It's very easily monitored with standard liver function tests. If you withdraw the dose, we've seen complete recovery of liver function in patients, and about 50% of patients can be re-challenged without long-term consequences. I think what's also, we've seen now with hepatotoxicity is that patients who've enrolled in a study with azole hepatotoxicity have been able to be treated with Allurifim. There's no crossover of the mechanism of action for the hepatotoxicity for the two different types of agent. Now, obviously, that also needs to be put in the context of what is the efficacy, so that we see the true risk benefit. And I think until we've got the full data from the study, we won't be able to put all that benefit in, the risk benefit in context. But I don't think we want to sort of overplay the hepatotoxicity until people have seen the safety profile, the efficacy profile as well. John, do you want to add?
I was going to say that the 7 to 8% rate is the rate of the events judged at least possibly due to Allurifim. We see there's a whole lot of stuff that goes on in heme malignancy patients, and a bunch of the heme drugs hit the liver pretty hard. We adjudicate every case. Everybody who's ever had their liver enzymes go up, they've come back down when we've either stopped or dose reduced. And we have about half the time we just kind of keep going, or we dose reduce or briefly pause, or combination of those two things. Either the liver gets happy with it, or it was never due to Allurifim. I mean, that's the problem with adjudicating these events. There's all kinds of stuff from shock liver to various chemotherapy. Just occasionally Allurifim really does. We know the mechanism. It inhibits electron transport in the mitochondria at a high enough concentration, and we dose to stay below that threshold.
Okay.
I think the other thing to add, Luis, is, with some of the infections that we've seen, if you've got somebody with serious life-threatening low pro infection who's failed all other antifungal therapies, obviously then, it's a trade-off. What is your benefit risk in that patient?
Alrighty, so now I want to give you a chance to ask questions of the audience.
Okay, so let me just bring up my questions. I think some of the questions actually relate to the presentation that Monica and others have given this evening. And I think one of the questions, we hear a lot in Europe about the increase in azole resistance, and particularly hotspots like in the Netherlands, where many centers are seeing rates of up to 30% in their hematological populations. And I'm just wondering how many of the physicians and colleagues on this session have seen azole resistance as a real clinical problem in the United States and in other countries. Is what we're seeing in Europe beginning to be translated into reality in other countries?
Yeah, I'm glad you asked that question. This is Shadi Hash from Indiana. Actually, we're seeing increasing numbers, and I work in the lung transplant program, and we use voriconazole a lot, sometimes preemptively, sometimes prophylactically, and invariably breakthrough infections are resistant. And with isavuconazole, I know the studies don't support this very much so, but I'm seeing more isavuconazole emerging breakthrough infections with increased MICs. Now that's a gray zone a little bit, because MICs are not well correlated with efficacy and outcomes. So, but yes, and it's not standard of therapy or care in the US to test for MICs on the aspergillus, which I don't necessarily agree with that. I think we should be testing because we're seeing increasing numbers. And Luis and I had a case we discussed a few months ago that had that issue, but I'm glad you brought this issue up. That's very important.
And allied to that is the challenge, if diagnostic testing is not being done routinely, how do you know your local epidemiology, and therefore how can you best choose your antifungal? These are obviously very real challenges, and given we know that many centers still use empirical antifungal therapy, how then do clinicians, the centers, target their use of antifungals? Or is it a case of following the guidelines, and only in the case of treatment failure do you then switch to a different class of antifungal?
Anybody else want to answer this question? We see people here from Mexico, from Brazil, Europe. They're all shy.
I mean, I know Marcio asked about fusarium. Obviously, fusarium is a big problem in terms of more, less common mold infections. And Monica, I know they have in Australia, they have a much bigger problem with low pro than other other countries do. And I think that's part of the challenge, isn't it? It's not only knowing, do you have azole resistance, but what is your next most common mold infection, and therefore how do you choose your agent?
Anybody want to answer?
I mean, there's no question that the azole pressure, right? I mean, if you want to use analogies on any bacterial, I mean, there is an azole pressure applied to the molds, epidemiologically and environmentally. And so it's invariably predictable that we're going to see more of these emerging resistance. Fungi are slower, and we will see them creeping up, and MIC creeping is being described. So just a matter of time, whether we see a dead dead man fingers mold in humans or resistant aspergillus in humans. It's just a matter of time.
I suppose the counterpoint to that is, are we genuinely seeing more, or are we just getting better at looking for them? Or is it a combination of the two?
I think of both.
Yeah, both probably.
Mhm.
Yeah.
Anybody else want to share what other molds are you seeing aside from aspergillus and mucor in your practices? Okay, do you have other questions, Emma, for us?
Yeah, just a final question. You know, it's an exciting time, I think, to be working in drug development in the antifungal fields. You know, I don't know how many parallel sessions there are going on now, but quite a few. What challenges as clinicians do you foresee with incorporating one or more novel antifungals into your treatment protocols and getting them on formulary in your centers? Or do you not anticipate having problems with bringing these new agents on board?
Anybody want to answer? I'm going to start really by sort of sharing the usual cost, the silo mentality I was talking about, where, you know, immediately the pharmacy looks at cost and says no, and it takes a while to explain why, you know, you may be spending more time and more money on the pharmacy, but then you're going to be saving money in other areas, right? Length of stay and outcomes, etc. So definitely the cost is a big driver always. You could have a perfect drug, but sometimes you can't even get in the door in the pharmacy just because of price. So that's very important. I see Monica turn on her camera.
Yeah, thanks, Lewis. I was just going to say, I think with these new drugs also, we've heard about less toxicity and drug-drug interactions, but I think also a big one is the spectrum. And we in Australia, in our hematologic malignancy patients, do see Lamentospora prolificans as our second next common agent to after Aspergillus. And so we don't have really an adequate treatment for this at the moment. Likewise with mucor, I think we need more options for treating mucor and fusarium. So it's these sort of, I think, niches that some of the new drugs have that will be most useful for us in getting them on formulary. Like having had the Allurifim trial running in our centre, we're having hematologists asking, you know, can we get this drug? So, you know, if they see it work for a patient, they want to use it. So I think it's that spectrum and that targeted for the difficult molds is going to be really useful.
I also think that not all of us have a Shan Zhang on staff. We need better diagnostics in our centers to really get to the molecular diagnostic of what mold we're dealing with. So I think there's a lack of infrastructure really for diagnostics that will allow us to access highly specialized agents like yours, right? Marcia's putting some comments in the chat as well. He's saying making a real difference, better toxicity profile, no drug interactions, besides being as effective.
And that's just, sorry, one final comment from me is if you have more questions, you'd like more information, please contact us. So we have a medical information mailbox, which is medinfo@f2g.com, or you can email me at emma.harvey@f2g.com. I know John gave you his contact details as well earlier. We'd be very happy to answer any questions that anyone may have.
Alrighty, well, we're 2 minutes away from closing the breakout, so please feel free to stay here or just go to the main room.
You know, Emma, I actually have to say something. For a lot of us, actually, if we were sites for studies, that helps a lot down the road, getting the agent on the pharmacy, and because the pharmacy and the pharmacy staff get used to it as part of their allocation, or even if it's a resource pharmacy section. But being a site actually helps a lot, and it's a lot of a lot of us do this for the study and for the research and also for introducing agents and new approaches to therapies and diagnostics. So that helps. So expanding offerings of sites might help introduce agents, and studies will speak for themselves and the data will speak for themselves. So nobody's going to make a decision just because they were part of a study.
Yeah, I think it's a very good point. I think, as John highlighted earlier on, you know, the costs involved with studies are quite significant. So we have to go to the sites that we know that can deliver the patients. But if anybody's interested potentially in becoming a study site, you know, do please reach out to us and we can put you in touch with our operations team who can do an initial assessment to see if your you know, if your center is a potential study site. We'd be very happy to have that conversation with you. They would be delighted to have that conversation with you, actually.
Any other final questions or words of wisdom for F2G? Okay, I think they're going to call us to the main room in a minute now. Thank you, Emma.
Thank you, everybody.